Forearm proximal radioulnar joint featuring pronation. So for passive range of motion, we're going to have the patient sit in a chair with the forearm on the table, and you want to have the elbow at 70 degrees, the open pack position, but this is going to be dependent upon the desired and achievable range of motion of the patient. So stabilizing proximally at the humeral ulnar joint with one hand, and you're going to stabilize distally on the dorsum of the forearm with the other hand. And here in green, I just put some suggestions for the finger and thenar eminence of that hand on the dorsum of the side of the forearm. You'll see this in the video in more detail and how to perform that. So you can teach the patient how to do this themselves. It's very easy. They can do it with their contralateral or their non-involved side, their non-involved arm. All they need to do is take their involved arm into pronation. And if they cannot do that, then the PT can arrange for them to do some type of passive range of motion some other way. So here are some considerations. So the normal end feel is hard, and the passive range of motion is used to establish normal range of motion and prevent contractures. And a normal range of motion is going to be 80 degrees of pronation. The pressure and the parameters for pressure would be if the patient presents hard end feel without pain and decreased range of motion, a more aggressive approach is applicable. And if the patient presents pain before resistance and an empty end feel, a gentle and cautious and progressive approach is needed. So here's the video. You can see with the left hand, we're going to stabilize distally the dorsum of the forearm. And then with the right hand, we're going to stabilize at the elbow at the humeral ulnar joint, taking them into pronation. And for the stretch, so to increase forearm pronation, you want to stretch the supinator and the biceps brachii. These muscles can be stretched to different degrees and intensities because the biceps is a muscle that crosses both the elbow and the shoulder. So you can put the forearm into pronation, which will increase the stretch of the supinator, but also increase the stretch of the biceps brachii. But to increase the stretch even more of the biceps brachii, we can take the shoulder into extension or horizontal abduction, which you will see in the video that I'm about to show. And recommended is a 30-second to 2-minute stretch. It's based upon really what you want for that patient to get out of the session and out of that stretch. So this is going to vary based upon what you want to achieve with the patient. So for a supinator stretch, we have the patient sit in a chair with the forearm on the table, stabilized proximally at the humeral ulnar joint, basically in the same exact way that you would do it with the passive range of motion. And the degree of the stretch can be modulated by extending the arm since the supinator crosses the humeral radial joint. And we want to make sure that we put their arm back into the anatomical or the resting position that we began from, just to make sure that we increase patient safety and increase patient comfort as well. So here's some pictures to show you the beginning and end of the supinator and the biceps brachii as they're being stretched. This is at the elbow joint. So here's the steps for the biceps brachii stretch. Have the patient stand. They can also sit as well. You want to use the same hand placement as the passive range of motion. It will be modulated slightly based upon the situation and the area that you are using, whether sitting on a plinth, whether sitting on a chair. So you want to bring the patient slowly into shoulder extension or horizontal abduction to increase the stretch at the shoulder while their forearm is in pronation. You want to make sure that you keep their forearm in pronation either at the end or the beginning of the stretch, because if you don't do this, you're not fully stretching the bicep as much as it can be stretched. And the patient can do this alone by holding their arm against the wall, and they can put their own shoulder into horizontal abduction. They can do this at home. It's very easy to teach them. So a study that I found by Wilk et al. Took low-load, long-duration stretching, and they used it to increase shoulder. They used it to increase elbow extension. So it produced a deformation in the involved collagen tissue with the goal and end result of elongation. They used a light resistance, and they worked within the patient's end feel manageable and within their sensation of pain manageable. And some things that you want to take note of during this stretch would be that you want to use a light resistance. You want to make sure the arm is internally rotated, the forearm is pronated, and the shoulder abduction from 60 to 90 degrees. You can see all these in the picture on the bottom right here. And resistance band is used with a weight at the end. So for the FIT principles, we have 10 to 15 minutes per treatment with 60 minutes of total end range time daily. And this is performed 4 times per day. So here's a video showing these different stretches. There's forearm pronation with the extension for the supinator and the bicep as well. There's another way you can do it. Now we're going to modulate how much of the bicep stretch we're getting. So while the forearm is pronation, we take the shoulder into extension. Here's another way to do it. While the forearm is a pronation, you're extending the arm. Here, the shoulder's in horizontal abduction with the forearm pronation, and that is for the biceps and the supinator. That one, they feel it. Typically, I feel like they feel the stretch most at the last stretch position we had them in right there. So for strengthening, I found an EMG article by Gorn et al. And the muscles responsible for pronation are the pronator quadratus and the pronator teres. And the study found dominant activity in the pronator teres compared with the pronator quadratus. And the quote I found that I liked was that the EMG readings indicate that during resisted pronation, the pronator teres muscle is the primary agonist. So we're going to use this principle while we perform the strengthening exercise that we're about to show. And something I thought was interesting was while the ability of the muscle to produce torque was dependent upon muscle length, motor recruitment, and length of the moment arm, the EMG readings showed activity of the pronator teres remained consistent throughout the forearm positions. So you can see here we have the forearm positions, full supination, mid supination, neutral, mid pronation, full pronation, and each muscle and the EMG reading of each. So steps for resisted pronation. You want to have the patient stand with the involved side ipsilateral to the door, and you want to tie a knot in the resistance band and put that knot in the door at a selected height. You can vary the height to increase the load at different points of the pronation movement, and resistance band level and the intent it can be changed either increase or decrease to increase or decrease the intensity. You have the patient hold the other end of the band with the radial aspect of the hand, and have the patient step away from the door until slack is taken out of the band. Then proceed with the forearm pronation. For strengthening, we want to do 3 sets of 8 to 10 reps at 2 to 3 minutes rest. And for endurance, we're going to do 3 sets of 12 to 30 reps with 1 to 2 minutes of rest. And this is all based upon the patient's condition, stage of healing, and degree of injury. And you would want to perform this around 3 times daily. So here is the exercise. Here I'm showing the patient how to perform the pronation with the resistance band, keeping the elbow as close to the body as possible, just so we're isolating the forearm pronation, the pronator teres. Since you're right here, their arm is a little bit away from the body, so I go ahead and apply a towel there between their body and the elbow joint in order to help them isolate their pronator teres and get a better exercise out of the hole. So immobilization, we're going to use convex and concave rule. So increasing supination, we want to do a PA glide, and increasing pronation, an AP glide is used. So grade 1 and 2 non-thrust oscillation can be used for decreasing pain, and we can also increase fluid movement. And grade 3 and 4 non-thrust oscillation is going to be for increasing the range of motion and stretching the joint. So steps, you can have the patient sit on a chair with the forearm on the table, and you want to make sure that you follow open pack position for both the humeral ulnar and the proximal radioulnar joints. So that's 70 degrees at the elbow and 35 degrees for the pronation. And you'll see that in the video. So palpate for the radial head, and we want to stabilize the ulna with the other hand. And we're going to proceed with the selected glide and the selected thrust that we want to perform. And manual pressure is dependent upon needed grade and pain. So here is mobilizations. You can see here that we put them in a 35 degree form and 70 degrees at the elbow. And here we're palpating for the radial head. With the right hand, we are stabilizing at the humeral ulnar joint. Here we are doing an AP glide. Now we're doing a, excuse me, I'm sorry, this is a AP right there. And the first one was a posterior anterior. And here are the references. I hope you enjoyed the video. Thank you for watching.